Good morning, good evening, good afternoon, everyone. I know you guys come from many different time zones. I'm Fabio Candotti. I'm talking to you from Lausanne in Switzerland. And we are here to have a interesting session on myths of vaccines, their safety, their efficacies, and all the rest that comes out from the questions that you have sent us. Our speaker today is Dr. Kate Sullivan. She's the chief of the Division of Allergy and Immunology at CHUV in Philadelphia, and she's also she holds the Frank R. Wallace Endowed Chair for Infectious Diseases. People that are in the field of immunodeficiency know her very well, so she really doesn't need more of an introduction than that. The next, do I move the slides? Okay, this is our disclosures. This information, I think you can read it, but basically we don't have the audacity to tell you what to do with your health and or the health of your dear, and so you always have to. We'll be happy to discuss things, but the final decision is between you and your primary physician. And this session is being recorded and will be publicly available after the end of the session. Please feel free to turn off your videos and rename yourself, and please mute the microphones at your hand.
All right. Thank you so much, Fabio. And how nice to see everyone, some visually and some I saw just listed as participants. Thank you so much for joining. Special thanks to Sumathi and Barb for thinking of this as a topic that would be of interest. And to all of you who sent in questions ahead of time, thank you, because it helped me reconfigure my talk so it's maximally useful to you. So all that being said, I'm going to share right now. All right. So I was asked to talk about vaccine safety, particularly for people in the post-gene therapy or post-transplant phase of their lives. I am going to cover that. I'm also going to talk a little bit about pre-transplant, because I think, judging from the questions, there's at least a few people that are pre-transplant. So I'm going to try and cover all of that. As I said, there were a lot of great questions that were submitted ahead of time, and thank you so much for that. I think, of course, what I think isn't necessarily correct, but what I think is that I have managed to answer most of them, not all of them, in the slides. So I'm going to ask that I go straight through my presentation. I'm sorry, it's all black print on white background, so it's not super fancy, but let me try and get through the material that I think is going to be maximally useful to you. And then we'll open it up for questions at the end. So I hope that's okay with everyone. So let me just start off with a big generalization. So when I think about the safety of vaccines, it's not only people with Wiskott-Aldrich syndrome. It's not only in people with SCID. I want to think about it generally in a setting of people with weakened immune systems for any reason. And so I'm going to give you this big generalization in terms of safety. So this isn't addressing efficacy. I'm going to get to efficacy in about 15 slides, but this is safety. So I divide my vaccines into two categories. There are inactive vaccines, meaning they're made from some tiny protein component, or the virus itself was killed and made into a vaccine, but for whatever reason, they are not live and they can't cause disease. So that's one pot of vaccines that I think about. And then there's another pot of vaccines that are live vaccines, and those are the ones where I put all of my attention and my concern and my focus. I'm going to give Sumathi, so I know this is being recorded, but I'm also going to give her my slides in case you want to refer back, because there are some slides that are not interesting to read, but have information that you might find useful. This is one of them. And so these are the vaccines that are inactive. And again, in different ways, right? These vaccines, some of them were made in the 40s, some of them were made in the 90s. And so they've been inactivated in different ways, but they include the classic early childhood vaccines, the Tdap, the Prevnar, hepatitis B, those are all given to infants. The influenza flu shot is inactivated, but the flu mist that you put in your nose, that's live. Polio, in this country, we give only the inactive vaccine. We don't give the live vaccine. That's not true around the world. Shingrix for shingles, if you're an older person and you're thinking about it. So the Shingrix is inactivated. There was a short-lived vaccine that was live for older adults. So again, let me just lay them out and make a list in case you choose to refer back to it. The ones that are in blue are ones that are not typically given in the US, but are available. And I've had some families that were in the military, and the question came up as to whether one person in the family could get the cholera vaccine or whatever. So I've listed them here. And that's what the blue ones are. They're ones that we don't typically give, but are available. Now, I said I sort of put my vaccines into two buckets. There's the inactive ones. I don't really fret about those. Then there's the live vaccines, and that's where the safety concerns come in for me. I'm going to talk about broader scale vaccine hesitancy and concerns that some people have later on. But for me as a clinician, these are the ones where I put my attention. And so it would be the chickenpox vaccine, which is Varivax in the US, and the MMR, which is the vaccine for measles, mumps, and rubella. There's a very, very attenuated, meaning weakened vaccine that's given early on in infancy called the rotavirus vaccine. Hardly ever causes disease in immune-compromised people, but it can. And then, as I said, the vaccines in blue are the ones that are seldom given in the US, but the yellow fever, for whatever it's worth, is a live vaccine. So this is where I put my risk attention to, and I evaluate every patient, no matter what reason they're immune compromised, in terms of their risk and benefit of getting one of these live vaccines. Okay, so now let's make it a little bit more personal. For non-transplanted patients, the MMR and the Varivax, which are the two live vaccines typically given in early childhood. Right now, the schedule is at a year of age and 4 years of age. The schedule changes, but right now that's what it is. And I would say if you polled 50 immunologists around the country, they would give you 50 different versions of, well, we kind of look at the T cells and we figure out what we think the risk is, and then we decide whether to give it or not. Honestly, that's the state of the art. There isn't, I will give you data at the end if you ask questions about what was it like in the old days when Wiscott patients got the MMR and the chickenpox vaccines. And I'm happy to talk about that. But right now, there's no rules, there's no guidance, there's no threshold, there's nothing to say if your T cells are over 500, give it, the safety's 100% perfect, or the opposite if you give it below. If you give it for T cells below 500, that the people are for sure going to get a rash and get sick. There's nothing like that. There's no data. It's really a pathetic state. Sumathi asked me to take this out, but I'm going to leave it in. And so the 22q deletion syndrome is super common. It's 1 in 2,000 people. So it's where we actually have some data. And there we know if the CD4 T cell counts are over 400, the likelihood of having an adverse event is very low. It's actually the only T cell immune deficiency for which we have vaccine safety data. That's why I left it in there. So there is, for 22q deletion, there actually is a threshold that physicians can look at and decide whether it's safe to give it or not. But for most other combined immune deficiencies, we have no data. And so that's why if you ask 50 immunologists, you're going to get 50 different versions of something like, well, we look at the T cells and we decide how strong they are, and that's how we decide to give it. Let me give you a little bit more context, though. It's not all doom and gloom. Many people with a combined immune deficiency will be on immunoglobulin. Not every last person, but I would say the majority would be. And most people will not give the MMR and Varivax to people on immunoglobulin. And why is that? Because the immunoglobulin soaks it all up in it, and so your body never sees those vaccines. If someone comes off immunoglobulin, you have to wait 8 months. It's not like it washes out in lickety-split. It does not. So if someone's on immunoglobulin and they come off for some reason, you have to wait 8 months before you can get the MMR and the chickenpox vaccine. And then the MMR and Varivax are not given to people on biologics, and there are some patients with Wiskott-Aldrich syndrome that are on TNF inhibitors, that have gotten rituximab, sometimes Dupixent for their eczema. Dupixent is the one, It's the one exception to the rule. If you're on biologics, you can't get the MMR and the chickenpox. What do I mean by biologics? So these are usually injectable drugs, and they are an antibody to some part of the immune system that you want to suppress. So for non-transplanted patients, it's hard to know what to do, except if you're on immunoglobulin, you're A, protected, and B, most people do not give the vaccines. But it's otherwise a tricky area. What about non-transplanted or pre-gene therapy patients? They can get all the inactivated vaccines without increased risk. So the tetanus vaccine, the pertussis vaccine, the Hib vaccine. So for people that are waiting to go on transplant, either are or are not on immunoglobulin, there's no increased risk associated with that condition in terms of getting the inactive vaccines. What about now post-transplant? So what happens post-transplant or post-gene therapy? Now, for people, we're lucky to have Fabio with us today, but for gene therapy patients, the vaccinations are always driven by a protocol, meaning there's a recipe book. On day 90, you get this blood work. On day 100, you get this physical exam. And on day 365, you get this vaccine if you meet the following criteria. So it's written down as a kind of recipe or protocol. So there's not a lot of, for the gene therapy patients, it's written down when and what criteria there are for giving the vaccines. For transplant, it's a little different, and there's different cultures at different transplant centers. I would say in general, some centers have a protocol and they say, we're going to wait a year post-transplant, we're going to stop immunoglobulin, and then we're going to start with the inactive vaccines, and then we're going to give the live viral vaccines. So there are some centers that just do it by protocol. They have a schedule. It's a kind of roadmap, and everyone knows when X, Y, and Z is going to happen. And I think that's fine. There are other centers that do it in a more boutique way. So it's a bespoke evaluation of each patient. Where are your T cells? When was your last immunoglobulin? Is your IgA coming up? So there are some centers that use a very bespoke or patient-specific approach for when to give vaccines. I think that's fine too. I don't think one is better than the other. Each center has its own culture that they've cooked up and they're comfortable with, and they have already demonstrated the safety of it, or they wouldn't persist in doing it. Now, I've mentioned a couple times that immunoglobulin, there are patients on immunoglobulin. In fact, most patients with Wiskott-Aldrich syndrome pre-transplant would be on immunoglobulin. I will talk again about post-transplant in a minute. So what does immunoglobulin do for us? Well, it protects us against all vaccine-preventable illness, except, there's always an exception, right? So immunoglobulin protects against vaccine-preventable illnesses, except COVID, flu, and pertussis. And it's different reasons. So for flu, it's because the virus changes each year. And so the immunoglobulin is made from blood that was taken 2 or 3 years ago. So it protects against those flu viruses, but not this year's virus. Whereas for COVID and pertussis, it's because the plasma is taken from adults, and there just aren't high enough antibodies in the adult plasma to provide protection. So you can give inactive vaccines while people are on immunoglobulin. I actually do not, but many people do. Some patients will actually respond to the vaccine. So there's a body of literature showing that you can, we say, vaccinate through the immunoglobulin, meaning you can detect a rise in the antibodies to pertussis, even though there's some pertussis antibodies in the product. So some immunologists will give all of the vaccines all over again. And so they'll give all the childhood vaccines on immunoglobulin. Some just give COVID, flu, and pertussis. I don't think there's any data to suggest there's anything right or wrong. I will say that immunoglobulin in general offers protection against tetanus and measles, against all of the vaccine preventable illnesses except COVID, flu, and pertussis. Now, pertussis might not be a term that you're very familiar with. It's the fancy term for whooping cough. And there is a ginormous outbreak of whooping cough across the United States. I'm just showing a few geographic locations. And why is that? Well, there's relatively low vaccine rates, but also adults turn out to, in some cases, have lost their immunity to whooping cough or to the pertussis vaccine. And so the adults are vulnerable, and then they catch it and they give it to kids. So right now it is offered to most pregnant women as a way of vaccinating the unborn child, but it's offered, it's not mandated. So there's a lot of pertussis out there right now. Let me tackle, this was at Sumathi's request, let me tackle the specific question of asplenia, which happens in Wiskott-Aldrich syndrome. And I'll say there's asplenia because your spleen was taken out, and there's functional asplenia where the spleen is in place but doesn't work very well. They both lead to susceptibility to what we call encapsulated organisms, and the two biggies are pneumococcus and Haemophilus influenzae. And why are they big deals? Have these kind of Teflon coats, so they sort of slip their way out of the clutches of the immune system. And so there's a special type of antibody made in the spleen, which is really helpful for clearing these encapsulated organisms. And so when your spleen is dysfunctional or it has been removed, that leads to increased susceptibility to infections with these encapsulated organisms. And so the CDC recognizes this, and they actually have a specific schedule for these vaccines. The schedule changes all the darn time. I look it up for every single patient because every year I swear it changes. But what it basically consists of is extra doses of Pneumovax, Hib, and the meningococcal vaccines. So to sort of summarize a complex schedule that's written out on the CDC website, it's basically an extra dose. And then they lay out whether there's another extra dose in 10 years or whether you call it good, and it's different for each of the vaccines. But I want to call out the asplenia situation because it is a little bit different. And remember, there's asplenia because the spleen has been taken out, and then there's functional asplenia because it doesn't work. Who develops functional asplenia? Lots of people get functional asplenia. And it turns out people that are immune deficient and have autoimmune disease are particularly likely to have functional asplenia, which happens in Wiskott-Aldrich syndrome. Oops, lost my, okay. So that's my medical presentation. But I work and live in the real world, and I understand that there's a lot of vaccine hesitancy. So there are people who have concerns that aren't my concerns, and that's fine. We're all real people. We're all influenced by the information that we hear, and I want to be sympathetic to that. And I think there's a lot of reasons for vaccine hesitancy. And if you are a hesitant person, hopefully I've captured what brings you to that position, but maybe I haven't. But in my experience, there's a big gulf in trust right now. Do you trust your doctor? Do you trust the medical institution in general? Do you have religious beliefs that make it less likely to have been exposed to a vaccine-loving environment? There are also perceptions of risk. Maybe you've had a negative experience before with a vaccine. Maybe you hate needles, that's fine. Maybe you have specific safety concerns. So I recognize that there's a lot of vaccine hesitancy right now, and I'm very sympathetic to it. There is a lot of information out there, and parents, they just want what's right for their kids. I totally get it. But let me talk about it a little bit. So there are what I call mythology. Now, I realize that's a polarizing term. If this happens to be your belief, you might find this term offensive, and I'm sorry for that. This is my term for how I see these, and I recognize that other people may view this differently. Vaccines cause autism. They have harmful ingredients. They're not necessary. Natural immunity is better than vaccine immunity. They cause cancer. They cause infertility. There's microchips in the vaccines, or they just are too much for a baby's immune system. So I'm not going to tackle all of these, but I do want to share with you a little information on some of the ones that I hear about more frequently. So concern number one, by far, is that vaccines cause autism. And so, first of all, what is autism? And that's part of the problem. it's a pretty squishy definition, right? It's characterized by challenges with social skills, repetitive behaviors, speech problems, and nonverbal communication. That's a pretty broad range of childhood behaviors. And so therein lies part of the problem. There's not a blood test for it. There's not an X-ray for it. It's a physician observing a child, usually over about an hour, and making an assessment. So there has come this concern that autism is caused by vaccines. Let me tell you a little bit, let me just tell you some facts. Autism is increasing rapidly around the world, and I'm not here to say why. We actually don't know why. The peak time of diagnosis of autism, which is the acquisition of social skills, roughly corresponds to the peak of vaccine administration, which is about 2 years. So most 2-year-olds are just starting to talk, they're just starting to engage, and that is roughly when there is a lot of vaccines. And I get it, autism is scary. Any parent would be smart to take steps to minimize risk. I totally hear you and I get it. But again, let's just look at some facts. So what is known and what is not known? We don't know the cause of autism, so we can't say 100% for sure that vaccines don't contribute in some small way. But I'm going to show you some data that suggests that if they contribute at all, it's actually in a really small way. So autism is increasing even in countries with limited or no MMR use, so India and China. Autism occurs in the Amish, who don't usually vaccinate their kids, at roughly the same rate as the rest of the US. And there's a pretty strong genetic component. That is not the whole story. But if one twin has autism and they have an identical twin, the identical twin has a 60 to 90% risk of getting autism. So there's a pretty strong genetic component. If it's a sibling instead of a twin, there's still a 10-fold higher risk of autism. So there's something genetic, but I hear you. The rise in incidence is faster than can be accounted for by genetics, right? We only reproduce roughly every 20 years. So the rate is rising faster than you could ever invoke by genetics. And it's a problem not having a cause. If we can't point to it, it makes it hard to say that vaccines aren't the cause. So this leads to uncertainty. But let me just show you a little bit of data here. So this is called, this is a variation on a Kaplan-Meier curve. So on the y-axis is cumulative incidence. So it's going up, the incidence is going up. Sorry. And this is from a study of children in Denmark. There's actually 2 studies, and they looked at over 1 million kids. And what you'll notice is that the unvaccinated kids actually have a slightly higher rate of autism than the vaccinated kids. Now, it's not statistically significant, but certainly it's not better than in the vaccinated kids. So this is from the first paper, and the second paper found roughly the same thing. So let me move on to mercury. And I hear this, this is probably the second concern that I hear most often. I don't want to give my child mercury. And so what's the real life of it? Well, in the US, again, I don't know what's going on in other countries, but in the US, only the multi-use influenza bottle has thimerosal in it. And thimerosal is the mercury-containing agent that's used as a preservative. So single-dose flu vaccines have it, and all other vaccines in the US do not have mercury. So the MMR does not and never did. The chickenpox, inactivated polio, and pneumococcal conjugate vaccines have also never contained thimerosal. So a lot of concern about thimerosal, but actually it was only ever in multi-use vials. What about this one? I don't hear as often anymore. There was a phase when I heard a lot about aluminum. It's used to enhance vaccine efficacy, so it's used to stimulate the immune system. It's present in most of the inactivated vaccines, not all of them, but most of them. So as a result of the vaccines, infants will receive about 4.4 milligrams, but they're going to get much more than that from their formula, and particularly if you use soy formula. So you're not really adding much to the aluminum burden of the child by giving vaccines. So here's another one of the slides where it's just in here for your reference. This is just the amount of aluminum in each vaccine. You can see it's actually pretty trivial amounts, like 0.2 milligrams. It's really a tiny, tiny amount compared to what we get in our diet. And then another concern I don't hear very much anymore, but I list it just for completeness, is that there's formaldehyde in the vaccines. And that is true, there is formaldehyde. And formaldehyde, it's a bad chemical. It damages DNA, it causes cancer, but it's also produced by us. It's a natural product of the cell sort of going through its daily business. So adults have naturally produced formaldehyde of about 14 milligrams. Babies, because they're smaller, have only 1.1. A typical pear, if you just go out and pluck one from the tree, has about 25 milligrams. Again, not added formaldehyde, just the pear produced its own formaldehyde. A typical apple, again, not extra formaldehyde that someone's spraying on it, just what the apple produced itself, has 8 to 10 milligrams, and the vaccines have less than 0.1. So a teeny bit of formaldehyde compared to what we get in our diet. Again, I'm just listing them here so you can appreciate that I'm not hallucinating these numbers. And that leads us to concern number 3, which will be the last one before we open it for questions. Vaccines aren't necessary. And this comes down usually to 2 main arguments. There's already herd immunity, so my child doesn't need any vaccines, and natural immunity is better anyway. Sorry, I have a frog in my throat. Let's see if that did it. Okay, let's talk about herd immunity. Okay, now I'm good. So what does herd immunity mean? I feel like there's, we throw it around all the time, and I think there's actually not so much understanding of what herd immunity is. Here is what it means. That the level of vaccination in the community, and you can define your community as an isolated desert island, the entire country, a region of the country, a city, you can define it however you want, but the level of vaccination in that community is high enough that spread is unlikely. And I made a little graphic that I hope will make that more obvious. But here's the weird thing. Herd immunity is different for every infection. So the numbers needed to prevent spread are different for measles than COVID, than mumps. So let me just try and explain this a little bit better. So on the left, I've got what I'm calling good herd immunity. So lots of people are vaccinated. So that virus in the middle with the spiky things, it's not going to get through the population that's vaccinated to reach that poor vulnerable person in blue, our immune deficient patient who can't get the vaccine or who won't respond to the vaccine. There's too many vaccinated people between the vulnerable person and the virus. When the level of vaccination drops in the community, the level of spread goes up. So the blue people are unvaccinated. So here you can see on the right-hand side, the virus can go through the blue person right under it, and that person then is going to infect the vulnerable immune deficient patient. So when herd immunity drops, this is the phenomenon that happens. And it can be slow. It can percolate slowly, like the measles outbreak right now. It can be explosive. It can take its own pace. So what are the numbers for herd immunity? Because measles is so contagious, you actually require a 95% vaccination rate to achieve herd immunity. Those numbers are lower for polio. 80% vaccination rate is sufficient to protect people around you. Same for pertussis. COVID's in the middle. So you can see the number of people needing to get vaccinated to provide effective herd immunity. It actually varies for each vaccine. And then the last argument that I hear is that natural immunity is better. And it's kind of true. It's just that there's a price to pay for natural immunity, particularly if you're immune deficient. So for some illnesses, natural immunity lasts longer. So measles is one. I'm old enough, I had measles when I was little. I should have antibodies lasting me into my 90s. So you do usually get lifelong immunity with natural infection, but as we've learned from the Texas outbreak of measles, there's a big price to pay. So there have been 3 deaths already. There's about a 6% rate of pneumonia, mostly in children less than 5 years and immune compromised. 1 in 1,000 get encephalitis. To me, that's a scary high number. And I just read a very touching memory in the New York Times today that Roald Dahl, the author of James and the Giant Peach Tree, he lost a daughter to measles encephalitis. And so he has tributes to his daughter in his next 2 books. And immune deficient people are much more likely to get that measles encephalitis, unfortunately. And then there's this crazy condition called SSPE that strikes about the same as the measles encephalitis, but it's slow motion. It happens later. It's associated with seizures and gradual neurologic decline. It's scary because you don't see it coming. People get their measles, they get better, go on with their life, and then 7 to 10 years later, they get this neurologic deterioration. So it's, I think, very scary. So measles, you get lifelong immunity, but at quite a cost, in my opinion. What about chickenpox? Also lifelong immunity with natural infection, but like measles, there's a price to pay. High rate of hospitalization, 2%. The complications are skin infections, pneumonia, bacteremia. All of these things are pretty terrible and require hospital admission. The fatality rate is lower than with measles, so about 0.05%. But then the people that get chickenpox, they're likely to get shingles as older adults. So if you get vaccinated to chickenpox, it reduces the likelihood of shingles. Granted, it's 40 years down the road, but no one wants shingles. Now, there are some special risks. So I started off by talking about safety. I'm just going to close out by talking about safety. So there are special risks for immune-compromised people in terms of the MMR and the Varivax. Remember, these are in the live vaccine bucket. So these are the ones where I worry much more about safety. So there are some people who can't sense viruses. That's not the group we're talking to today, but there are some people who are missing proteins that tell them there's a virus in your body, wake up. Those people have a high frequency of adverse events related to the MMR or the Varivax. But here today, we're mostly talking about people with low T cells or not so perfect T cell function. So what do we do? As I said, if you ask 50 immunologists, they're probably going to say, well, we look at those T cells. How many are there? What's their function? And then make an assessment as to whether the risk and the benefit, what is the risk and benefit for that specific person. There's another consideration in that people with Wiskott-Aldrich syndrome will sometimes be treated with rituximab for various reasons, for autoimmune disease, for lymphoma. It doesn't seem to increase the likelihood of adverse events, but people are not very likely to respond. On the other hand, people, when they get rituximab, which is it's an agent that basically depletes the cells that make antibodies, they are likely to be on immunoglobulin on a weekly or monthly basis. So they have protection, so less often an issue for them. So lifelong immunity is not always the case. So I talked about measles and chickenpox because there you do get lifelong immunity. It's just that there's a price to pay. And lifelong immunity is not always the case with natural infections. So some good examples are pertussis. One of the reasons it's not well represented in immunoglobulin products is many adults have waning immunity to the vaccine that they got as a child. COVID, doesn't matter whether it's natural infection or vaccine, you're going to get antibodies for 6 months, and that's all you get. Mumps, it's roughly the same for natural infection and vaccine. And for RSV, the current vaccine that we have is actually an antibody that's given to babies, so it only really lasts 5 months. So you can see there are a lot of infections where you don't really get lifelong immunity. So let me end with just vaccines overwhelming the immune system. Boy, we all had a lot of infections. If you don't remember it, it's a blessing. If you have young kids, you know, little kids get a lot of infections. So toddlers get more than 1 infection a month. And I'm going to share a study with you in a minute where over half of their days, people could swab a virus out of their nose. So these are the infections, meaning causing symptoms, but we are also populated with billions of bacteria on our skin and in our gut. So we are exposed to a lot of foreign things. So just to sort of, I think I got on a little bit of a jag here, so please forgive me. It's just making the point that kids have a lot of infections, and these infections have a cost. So early life infections lead to risks of asthma and a higher infection rate down the road. And the Big Love study is first of all, I love the name, but second of all, they actually went around to houses and swabbed kids' noses every week for a couple of years, which I think was really heroic. I can't imagine the kids or the parents were super excited about that. But importantly, they found the virus about a quarter of the days that they went to the house. So we are exposed to a lot of stuff as little kids. And so many of these infections are prevented by Hib, the pneumococcal, and the RSV vaccine. And so vaccines really are in this landscape of all of the stuff on our skin and in our gut, and the toddlers getting all of the infections. Vaccines feel like a tiny little drop in the ocean. Compared to the natural infection burden, I think vaccines are a minimal burden on our immune system, but that's my opinion. COVID vaccines get special attention. There were a lot of concerns that I used to hear. I hear much less about them now. I heard a lot of concerns early on the vaccines were developed too fast. Well, they actually rested on the shoulders of a previous Ebola vaccine, and the people that got the Ebola vaccine, which are not mostly in the United States, I'll grant you, but the people that got the Ebola vaccines don't have any long-term harm from them. And we tested, we, meaning the medical community, not me personally, tested a gazillion people to demonstrate efficacy. So the Pfizer vaccine alone was tested in 46,000 people. The Shingrix vaccine, which is the shingles vaccine, was tested in only 1,600. So comparatively speaking, a lot of people were tested for safety and efficacy. One of the concerns, again, that I heard early on was that the vaccine causes infertility. This has been studied multiple times, and the pregnancy numbers were no different. I've also heard, actually from someone who works at CHUV, that the vaccine has microchips. I think it's maybe technically feasible, but to what end? And then the concern that it will change our DNA. And so this comes from people worried about RNA somehow impacting our chromosomes, but it actually doesn't get to our chromosomes. So it stops short in the cell. So within the cell, it actually just lands on the outer bit. Does the COVID vaccine work? It actually does. So these are different studies in non-immune deficient patients getting the vaccine, and it does prevent hospitalizations. People do still get sick, but they don't get hospitalized at the same rate. And then this is showing protection from death, which is, I think, at the beginning of the pandemic, I think the thing that I worried about the most. And so the COVID vaccine has been shown to be effective in immune compromised people, but I find that the choice to get it is very personal. So let me just summarize before I open it up for questions. I think a key point that I hope you took away is to distinguish between the live vaccines, where I think we all want to be really thoughtful about pros and cons of giving them in immune deficient patients, and the inactive vaccines, where at least in my mind, there's not really a safety concern. I personally treat them very different. I stick them in separate buckets and think about them quite differently in people with compromised immune systems. And then I brought in this other theme about immunoglobulin, which protects against most vaccine preventable illnesses, just not flu, COVID, and pertussis, but otherwise is a great strategy for protecting people. So I'm going to end there, and hopefully we have plenty of time for questions, because I know people were really thoughtful about that.
Well, thank you, Kate. That was fantastic. So, Maddie, can I ask you how much time we have, just that we organize ourselves in
Let's say 15 minutes, Dr. Sullivan. Yep. Would that work for you?
It is about 1 hour. Okay. So why don't we just give space to the person that wrote a question in the chat, to acknowledge that. This is a patient with Wiscott, non-transplanted, not treated. If I'm wrong, please correct me. This patient is now 15-year-old, and he received the MMR at 1 year. He had a reaction, a rash, that apparently was okay. And now periodically his antibodies are checked and they are within limits. I guess these are protective limits. Is it worth taking the second dose of the MMR?
I think if he's I mean, for me, if he's protected, he's protected. He doesn't need the second dose. I would want to know for sure what those antibody levels were to make sure that they were in the strong end of the protection range, especially now with measles in the community. I think 5 years ago, I might have had a different approach, but I think as long as they're monitoring the titers and he's got protective levels, I don't think you have to give the second vaccine. You could if you wanted to.
Okay, thank you. somebody is thanking you for your presentation, and then for pro-transplanted patients with full T-cell reconstitution without confirmed B-cell function in IgG production. How does the immunoglobulin replacement therapy compare to the level of quality of protection if the same person was fully immunocompetent and vaccinated, excluding the big three? In other words, how much more protection, if any, does the vaccine induce active immunity would provide over IVIG?
That's a super interesting question, and we might just pull Fabio on his ideas here. I guess my thinking about this would be this person would have the average of the adults roaming around the US, right? So the immunoglobulin product comes from adults like me who are just walking around doing their daily business. So I would say it's roughly the average of adult protection, which is pretty good. But Fabio, what do you think?
I think I agree with you. I think the possibility that an additional T-cell immunity would would develop after the vaccine and would provide some additional measure of protection. But definitely there are no studies that tell us how much that would be and if we really added to the protection. But I think it is probably the answer you gave, Kate, is my favorite one. Have you or your colleague noticed an increase in vaccine hesitancy among parents, patients in the past several months?
I would say I've noticed an increase since the COVID epidemic. In the last few months, I don't think I see enough patients where the vaccine question is coming up that I would necessarily be able to tell. But certainly since the pandemic, I've definitely noticed increased hesitancy for sure.
If I can ask you,
Europe? So Fabio works in Europe. Is it different in Europe?
No, I haven't seen a lot of hesitancy these days. I think that there was a lot of that sentiment during the COVID and the 2 years past. But I live in a country where natural immunity is much better than vaccines. So, and that hasn't changed.
Okay.
But one question that I have perhaps that has to do with COVID because of the non-immunological, non-infection complications that the COVID vaccine has been accused of. One of the general responses to that that came out and hold place during the COVID is that if the vaccine, yes, can have complications, but for the patients that had serious complications, perhaps they would have had the same or worse if they had the natural infection. What do you think about that discussion?
There have been a few large-scale studies that have come out recently. I'm sure you've seen them, largely in adults, not kids. I wish we had comparable information in kids, showing that after COVID, so not long COVID, but after COVID, in the year after COVID, many autoimmune diseases spike. And it's across a whole range. So it's autoimmune hemolytic anemia, it's idiopathic thrombocytopenia purpura, which I know this group knows about. It's essentially all autoimmune disease, including arthritis, is much higher in the year post natural infection with COVID. If you look at the comparable sorts of things after the vaccine, you see, a smidge of myocarditis with one vaccine in the immediate post-vaccine period, but you don't see this range of autoimmune diseases.
A question about a patient that is 1 year post-transplant and 2 years old overall. Does the vaccine scheduling start over with the original intended frequencies, or do the vaccines need to be started to catch back up with the original schedule?
Yeah, most centers will start from scratch. I think there is some variation from center to center, but most centers are going to start from scratch.
Yeah. For children post-BMT who are trialing off the IVIG treatment, needed to wait 8 months to try to vaccinate. Should these children be isolating, or are they or higher risk of contracting infection since they are off IVIG and not vaccinated?
I'm wondering if you're referencing specifically measles or just general infection risk.
It's not clear.
I'm going to take a stab at it and you let me know if I go down the wrong path. So in terms of general infections, generally there's a ton of monitoring that happens post-transplant when someone comes off immunoglobulin. And so they'll know if the levels are dropping too low and if the protection generally against infections is too low for it to be safe. So generally there's a lot of monitoring in that what we call the washout period for immunoglobulin, because we don't want to miss someone being vulnerable and needing to go back on. So I would wager your center is doing that.
And the 8 months wait period is standard?
The
After
8 months, you have to wait 8 months before you could get the MMR and the Varivax. It's not 8 months for all vaccines. So usually after 3 months, they'll start with the inactive vaccines. They'll start with the Tdap or whatever is age appropriate. And then after they give the inactive ones, they will measure titers to make sure the responses are there. And then if they get to the 8-month period and everything looks cool, they'll go ahead and start with Varivax usually. And that's because we have a drug that'll treat it if there's a breakthrough infection. If everything goes great with the Varivax, then they'll go ahead and give the MMR. So there is sort of a schedule that most centers would use.
Right. Okay. Then, yes, what is the recommendation for non-transplanted patients in the US with the class 1 variants, genetic variants, who are traveling to areas with increased measles incidence or prevalence?
Not familiar with the terminology class 1 variants.
So the class 1 variants are the variants that have been described to be associated with a milder phenotype.
The 5' ones.
The 5', yeah.
Okay. And you're traveling to a place with measles. Well,
with measles.
And your child has been vaccinated or not? I'm going to say not vaccinated.
Yeah.
If you're traveling someplace where there's a lot of measles, I'd give serious thought to getting a dose of immunoglobulin before you go. If it's a place with just kind of low levels of percolating measles and it's not anything more than the city of Philadelphia, which is my standard, which is to say nothing, I'm not sure I'd sweat it.
Yeah.
It's you've probably gathered there's not a lot of rules here. It's a lot of shared decision making with your immunologist or transplant person or whoever's doing hematologist, whoever's doing the management. But I would, if you're legitimately going to a region of the world where there's a lot of measles, I would think about immunoglobulin, not just for measles, but I'd think about it for a variety of infections that you might encounter.
And are vaccines more risky after transplant than not? Than someone that has not received the transplant?
So I'm probably going to ask Fabio for some input here, but there's different levels of engraftment. So some people have engraftment that's spectacular. It essentially regenerates a largely normal looking immune system. T cell numbers are normal, B cell numbers are normal. They mature appropriately. Everybody's making immunoglobulin. So for those folks, I wouldn't think that the risk would be increased over the general population. But there are folks who are post-transplant who don't get fabulous engraftment. So someone in the chat said, my son has T cell engraftment, but not B cell engraftment. And so there are states post-transplant where the immune system doesn't reach spectacular. It reaches something less than perfect and spectacular. And those folks very much need a customized approach to those vaccines because it's going to depend on the T cell count, the T cell function, also whether there's any graft versus host. But Fabio, you probably think about this more than I do. So,
right. So I think we are talking about live vaccines for
yes.
the answer to this question.
I hope that's true.
Yeah. And it is true that there are schedules and measurements that you can do, but those are very imperfect. So I agree with Kate. In most cases, those schedules allow to vaccinate patients without risk, but is the possibility that some proliferation or some numbers that are defined as appropriate to responding to live vaccines are actually not, and it might have a complication. So that we cannot rule out at this point, because our measurements are imperfect, and we have to accept that. At what point can my healthy child receive live vaccines while in the same household with my SCID or immunocompromised child? If I have to be, we have to be separated to vaccinate my healthy child. How long to be safely? How long should they be safely? And what should they safely to be separated?
Yeah, that is a very tricky question. So the party, I'm going to tackle chickenpox because it's the one where there's some data. So the party line on chickenpox is if you give the chickenpox vaccine to the sibling of the child with SCID, and there's no pox, meaning no vesicles, no scabs, no nothing, that they are not contagious. I don't actually know where that data comes from, but that's the party line from infectious disease people. From MMR, actually don't know if there's comparable data. So I'm sorry, Barb, I'm going to fail. I'm going to get a failing grade on that question.
I don't have an answer for that either. And again, from Barb, if my child is off of IVIG, but it was only ever approved to receive kill vaccines, what steps should we ask our pediatrician to take now that there are measles outbreak in the state?
Yeah. So I guess the question is, did they not give the live viral vaccines out of fear, right? This is a post-transplant, well, I guess post-transplant patient. And they just were afraid to give live viral vaccines. Or did they make a judgment based on some laboratory criteria and said, no, I'm sorry, your child really, their immune system isn't able to tolerate these live viral vaccines? Again, sort of the one trick I have in my back pocket is if someone is in an area with a big outbreak, you can give immunoglobulin, which will be protective. Now, it sounds like this person just came off immunoglobulin, which I'm sure was a landmark. But the risk of measles is not insignificant, particularly if you're immune compromised in any way. And so I would say the better part of valor is probably to ensure protection and worry about reaching that landmark later on. But I do understand coming off immunoglobulin is a big benchmark for families. Fabio, can I ask you a question that came up to me a minute ago? So in the gene therapy protocols, what are the criteria that they use? So I'm sure those are very formulaic. What are the criteria they're using to give live viral vaccines?
In most cases, we take the criteria from the bone marrow transplant, allogeneic bone marrow transplant folks and area. So it is a time after transplant, after gene therapy in this case, at least 1 year, and then the number of this reconstitution of T cells based on the numbers and proliferation assays. So there is nothing we call it original there. Is really taken from the field of allogeneic transplant.
And is the fraction of gene therapy corrected cells part of that equation?
Not really, no. It is in most cases the fraction is high enough that that doesn't really affect the total number, but not is the gene correction percentage comes into the when we want to those the specific function of the protein that was missing and now is suppressed, but not for the full full immunological testing, the full immunological evaluation.
Okay, thanks.
Okay, let's see if I can get another one. Can inactivated vaccine cause autoimmune reactions in patients with immune system who has a serious Wiskott by triggering the immune system.
Yeah, you know, we worry about it a lot. I work with another group here where there are mitochondrial diseases and diseases that predispose to like an antiviral reaction, and we worry about it a lot. We actually don't see it. So there's one, as far as I know, there is one study, and it's my study from the early 1990s. So I don't know how relevant it is, but there wasn't an increase specifically in Wiskott-Aldrich syndrome of autoimmune disease post-vaccine. Not every Wiskott patient responded fully to the vaccines. But what I will say is in the comparator group that didn't get the vaccines, there was a ton of chickenpox and a ton of recurrent chickenpox. So they got it once, and then it's like they got shingles over and over again. So I will grant you that paper's from a really long time ago, but that sort of spurred my enthusiasm for trying to safely give vaccines to boys with Wiskott.
And can you apply to the answer to this question the same argument about if you were supposed to get a severe COVID, you probably I'm not saying it right, but if somebody is developing autoimmunity because of a killed vaccines, would that person also have had a autoimmunity if exposed to the natural virus?
I think it's super hard to know. Those are tough to untangle.
Okay. I think we reached the limit. We are 2 minutes over. Sumati, is that okay to terminate here?
Yes, I believe so. Thank you. Thank you both so much. Thank you, Dr. Sullivan, for just a fascinating talk. I learned a lot from it, and thank you for the illustrations which showed everything. And Dr. Candotti, as always, thank you for being a wonderful moderator for us. Barb, do you have anything else?
No, I think that's it. Let everybody go on with their afternoon, but thanks both of you very much for being here today.
Yes, and yes, we will be sending out a recording. So thank you to everyone, and have a great rest of the day.
The rest of the day. Thank you. Thank you, Kate.